Thank you, Dr. Becker, for that kind introduction. Hi, everyone. So, yes, I'll take you through the adult approach to acute migraine, and we'll talk a little bit about medication overuse headache as well, and then Dr. Rajapaski is going to speak about the pediatric side. So we'll start with just a short disclaimer here, which is to say that some of the slides that I'll be using in today's presentation have been previously developed educational programs actually for migraine, for GPs and neurologists, as well as other healthcare professionals. One of them is called the Migraine Learning Compendium, and the other one is called Head Start. These are great kind of slide decks that I've used before to teach for acute migraine treatment and medication overuse headache as well. Just to mention that these slides have been developed by headache experts across Canada, and all the content has been reviewed and it's evidence-based. But the financial support for that has come from AbbVie, so I do want to recognize that. And also the information that's presented, of course, is the speaker's opinions, and if that's the case, we will mention that. And there may be compounds that I discuss here that have not been Health Canada approved yet, but that you may hear about or may be coming down the pipeline. So in terms of my own personal disclosures, I have worked with various industry partners in terms of consulting fees, advisory board members, speaker borough or honoraria, and some grants and research, and also some other sponsorships as well for research, specifically in spinal CSF leaks. So in terms of today's session, there's sort of three objectives that we have. The first is to describe the available acute migraine therapies, including CGRP blockade as a novel approach, apply some practical strategies to optimize acute migraine management, and then thirdly, recognize and treat medication overuse headache, because that's quite common, unfortunately, in patients we see with headache. So let's start with, what would be some of the goals of acute treatment of migraine? And this was the American Headache Society position statement, which still stands true. This was put together in 2019, but still holds true today. So what are some of the goals that patients have for their medications when we're talking about acute or symptomatic therapy specifically? So patients want rapid and consistent freedom from pain and associated symptoms without recurrence. They want restored ability to function, so that's a very important factor for them. Minimal need for repeat dosing or rescue medications, optimal self-care and reduced subsequent use of resources, and minimal or no adverse events. So basically the perfect drug, which doesn't exist, but, but essentially these go in the order that patients desire. So the first thing is the rapid, consistent freedom from pain, and the second really is that ability to function. So when we're looking at acute migraine treatment, this is a strategy from the Canadian Headache Society actually publication that goes back now to 2013. So you'll see here that the newer medications are not part of this because this was back from 2013, but still very applicable otherwise with the other medication categories that we use. So basically we use what's called a stratified care approach when we're treating migraine headache, which means that basically match the severity of the headache to the appropriate medication that would be most suitable to treat that headache. So essentially, if you're dealing with a mild to moderate level headache, potentially over-the-counter analgesics like acetaminophen or ibuprofen or other NSAIDs might be suitable. But when you're getting to the more moderate level of headache, this is probably where you start to think of other actual prescription type medications. So typically you would be using potentially a prescription NSAID, often with a triptan in association with it, or potentially a triptan as a first measure. And then certainly when you're dealing with more severe migraines or refractory migraines, you want to look at combining treatment options. So looking at using medications that have different modalities of action, such as an NSAID plus a triptan, or now we have the gPANT medications as well that we'll talk about. And this is also cases where it would be appropriate certainly to refer patients to neurology. But the important thing, I think, to remember with all of these headaches is that whether it's a mild, moderate, or severe headache, it's really important to treat the headache early. So we describe this to our patients like a forest fire. So if you have a very small forest fire and you're trying to put it out, it's much easier to put out that fire with a little bit of water when it's early on in its stage rather than waiting until that fire has spread. So really treat that headache as early as possible. But of course, you have to be careful with medication overuse, which we'll talk about as well. But in general, we do recommend to patients to treat the headache early. There's lots of good evidence that medications work much better when headache is treated early on. So when it comes to more refractory migraine, what are some of the recommendations? So certainly we talked about combining classes of medications. So for example, a triptan and an NSAID. And again, a gepant medication that we'll talk about could come in anywhere here. And then of course there's some sort of rescue or extra medications that can be prescribed for patients as well. So for example, some of the NSAIDs that we might use a little less commonly, such as ketorolac or endomethacin, or some of the antipsychotic medications, for example, like chlorpromazine that we may use less often, potentially steroids if we have to in cases where patients can be very refractory. This is another case where nerve blocks might come into play. Yay. Dr. Jarvis. And then, of course, as a last resort there, we have opioid combination analgesics as well. But again, if patients are using this just as a rescue measure once in a while, that can be allowed in patients that don't necessarily respond sufficiently to the other medications. And then we also have dihydroergotamine, which is best given as sub-Q injection or intravenous. So sometimes we do admit patients that have status migrainosus or more severe migraine, but we try to avoid that as much as possible. So as an outpatient, sometimes we prescribe subcutaneous dihydroergotamine. You could do 1 to 2 week courses of that, and it can be often effective to break that cycle of headache that they have. And of course, you're combining your antiemetics, your NSAIDs, and other things in there as well. So going to the triptans now, these are the ones that are available in Canada. So there's 7 of them available. They have some different qualities to them. Some work faster, some work slower, some have longer half-lives. So I think it's important to kind of understand the character of the headache that the patient describes so that they could be better suited to choosing a medication for them. So for example, if a patient has significant nausea or vomiting with their headaches, or for example, if they have headaches that come on very rapidly, you want to give them something that works quickly. So something like sumatriptan injection, otherwise known as Imitrex, would be certainly suitable in a case like that. Or zolmitriptan nasal spray, so that if they're having nausea, vomiting, they don't have to really worry about taking a medication. And these also work quite quickly. So the sumatriptan injection works the fastest, followed by the zolmitriptan nasal spray. Some of the others, like rizatriptan and elatriptan, are sort of middle grade, so they're only available as oral, but they do have, the rizatriptan does have this oral disintegrating tablet formulation as well, which makes it easy to take if there's no water, but really it doesn't work any faster actually in terms of the pharmacokinetics. It's essentially the same as the tablet, but just more convenient to take. And then almotriptan is a nice sort of gentle one, so if patients have not tried a triptan before, might be a good one to start off with, and it does come in the half dose of 6.25, so perhaps a more gentle one to start with. The ones down at the bottom, like naratriptan or frovatriptan, those are very long-acting triptan medications. So particularly good in cases like menstrual migraine or menstrually related migraine, because those attacks can be more difficult to treat. And actually, those are often used as mini prophylaxis or mini preventives for patients that have menstrually related migraine, in that they can actually start, if they have a predictable menstrual cycle and predictable headache that comes with it, they can start a couple of days ahead of that, start to take the medication in a BID fashion. So for example, for overtriptan, we would dose 2.5 milligrams BID, and then they could do that for 5 to 7 days. As high as 7 days, but they don't have to go that long. And that often can help to mitigate or reduce the headache that they have associated with their menstrual cycle. So different uses, but we generally do say that if a patient doesn't respond to one triptan, try another. We often try multiple, sometimes all of them in a patient. And interestingly, some patients respond to one but not another, and there's no really good way to predict that. They do have some slight differences, so it is good to try a few if a patient has only tried 1 or 2. And again, important to tell the patient to take it early on in the headache and to try it at least for 3 headaches, we say. So try at least 3 headaches, and if it doesn't work and if they've tried it early on in the headache, then that medication probably isn't the right one for them. So some of the other options that we have, parenteral or sort of fast-acting options. So diclofenac powder solution, or Cambia, is a great option for patients. It does work quite quickly. It can start to have onset of action within even 5 minutes, but reaches Tmax within about 15 minutes, so very fast-acting. It also kind of bypasses that gastroparesis that can happen with migraine, that slowing of the gut motility. So a good medication option and a great adjunct with a triptan or a gepant. Suppository options for patients that might have nausea or vomiting, and those are available in diclofenac, endomethacin, and naproxen. The nasal spray, we talked about the zolmitriptan. Sumatriptan has a nasal spray as well, but we tend to use it mostly in the injectable form. We talked about DHE as well. And then if you have a patient that really doesn't respond to other things, then ketorolac IM can be prescribed as well for them to take as an outpatient. And then of course, if there's access to emergency or other places, then ketorolac IV as well. And then the antiemetics are good adjuncts as well. They're not on the slide, but certainly great medications that help with absorption of medication and also help with the nausea aspects. And things like metoclopramide or dansetron are common ones that we use. So some of the other migraine treatment strategies, so we've talked about acetaminophen being generally helpful in some cases when the migraine attack can be mild, and sometimes as a good adjunct as well. So sometimes the patient will say that a triptan or an NSAID may not work sufficiently, so they can actually combine sometimes acetaminophen with that, and it can work better for them. Caffeine sometimes, if used appropriately and not too often. We don't want them to have caffeine withdrawal or, overuse from the caffeine, but as a adjunct to their acute pain medications, it can sometimes work well and has analgesic effect. Combined analgesics, we do use sometimes, so we try to avoid them if possible, but if we have patients that don't respond to our typical medications, it can still be used on an occasional basis. We do mention to patients that it has a higher risk of medication overuse headache, so we really try to recommend that they use less than about 6 to 8 days per month if possible. So really as just a final rescue to use. DHE we already talked about, less likely to be associated with medication overuse headache, but it can be a little bit harder for patients because we recommend it, as mentioned, as a sub-Q injection. Patients can have pain with the injection, sometimes redness at the site, that type of thing. It does come in a nasal spray as well, so it can be prescribed that way also. And then, of course, there's sort of conservative strategies as well that patients can use. So cooling devices, heating devices, depending on which works for the patient. There are also devices like the Cephaly device, so neurostimulators like trigeminal nerve stimulation or other types of stimulators as well. And then opioids are on this slide to be really used as a last resort. So we do have patients where they have contraindications or we've absolutely tried everything and we're stuck, we have to use opioids. So I think if that's the case, that's okay, but just using it responsibly and making sure the patient knows the risks of medication overuse as well. And I think at that stage, it's important to have a pain physician or a neurologist involved in the care of the patient as well. So going on now to some of the evolving options for acute treatment of migraine. So let's talk about these GPANs. So this is all related to CGRP or calcitonin gene-related peptide, which is this small protein that's implicated in the pathophysiology of migraine. And how do we know it's implicated? There's actually many mechanisms by which we know that. So for example, during migraine attacks, we know that CGRP serum levels are elevated, so they rise. We know that CGRP infusion actually triggers migraine-like headache attacks. Triptans, we know, reduce CGRP, and that's their mechanism of action, one of the ways they work, through agonism of the serotonin receptors. And then we have selective antagonists to CGRP and its receptor, i.e. the GPANs, that have effectively shown to be useful for migraine headache. And CGRP is released at the peripheral nerve endings, as you can see here, the trigeminal nerve afferents, but also centrally as well. And we think that the GPANs likely has action at both sites, whereas the monoclonal antibodies that are used for prevention, which I won't get into because that's tomorrow's talk with Dr. Nash, those act more peripherally, we think. So in regards to the GPANs, as we talked about, it's an important neuropeptide that's involved in the pathophysiology of the pain part of migraine, but also it's actually important because it's a potent vasodilator. So when we're blocking it, there will be some inhibition of vasodilation. It's not a direct vasoconstrictor, but it does inhibit vasodilatation. It also acts on mast cells, so it can be helpful to reduce inflammation as well. So basically, these GPANs are receptor antagonists, so they bind the CGRP receptor and inhibit the natural function of the CGRP ligand and prevent the downstream pain effects related to that, as well as the anti-inflammatory effects, etc. And based on animal models, we know that CGRP blockade or antagonism has not been actually associated with the same mechanisms involved in medication overuse headache. So that's an important concept actually, because with all of the other medications we have, like the triptans or other medications we use for acute therapy, we're always worried about medication overuse, but this is the first class of medications that's not only specific to migraine pathophysiology treatment, but also has been shown not to be involved in the same mechanisms as other medications for medication overuse headaches. So a good option to use if patients are having frequent headaches that they need treatment for. So in terms of the GPAN, so these are the ones that have been in development, and all are actually available in the US right now, but in Canada we just have currently atogepant, which is a preventive GPAN, so we don't use it acutely. And we have ubrogepant, and ubrogepant we do use acutely, so it's for the acute treatment of migraine headache attacks. Rimegepant is not yet available in Canada, but hopefully will be coming within the next year, and is both actually a preventive as well as an abortive medication, so it can be used for both purposes as well. And all of them work at the CGRP receptor by antagonizing it. As you can see there, the ubrogepant is an oral tablet. Atogepant is oral as well, but the rimegepant will have an oral disintegrating tablet as well. I won't discuss zivegepant because it's just going to be available in the US. It's not, as far as I know, it's not coming to Canada, but it is available as both a nasal spray and an oral tablet. So for now, I think because we're talking about acute treatments, we'll focus on ubrogepant and rimegepant because those are the two that we would use for symptomatic or acute therapy. So let's go through some of the efficacy data for that. And we'll start with the triptans first, just as a basis of comparison. But I do want to mention that the numbers you see here are not head-to-head trials. So these were not head-to-head trials. They were done independently, and some of them, had different patient populations. So do keep that in mind. But I think just for the purposes of ease, we've put it on one slide here. But you could see the different colors for the different triptans there, and just keep in mind that, for example, sumatriptan here, they've provided the data for the 50 milligram dose, but we often use the 100 milligram dose in adults, which I think is more effective. Same thing with zolmitriptan, it's the 2.5 milligram, but often we're using 5 milligrams. Rizatriptan, we're often using 10 milligrams. So these are some of the lower doses that are on these slides, just because we have that data available, but the higher doses are a little bit more effective in general. But just so you get an idea, so pain relief at 2 hours, somewhere around about 50 to 60% or so with the triptan medications, just as a ballpark. And pain freedom at 2 hours, again, we look at the ones that are at the appropriate doses there, somewhere between sort of 25 to 30% or so pain freedom at 2 hours. And then sustained pain relief from 2 to 24 hours, approximately 40 to 50% again. So in terms of looking at ubrogepant now, so this one had a co-primary endpoint, the first being pain freedom at 2 hours post-dose. So you can see there that ubrogepant, which is available in 2 doses, a 50 milligram dose and a 100 milligram dose, it's approximately 20% at 2 hours. And then these were two very similar randomized clinical trials, so Achieve-1 and Achieve-2, and with Achieve-2 we can see a very similar result as well, that about 20 to 21% of patients or so are pain-free at 2 hours. The second co-primary endpoint here was the absence of most bothersome symptoms. So this has become a requirement now to do clinical trials, is looking at most bothersome symptoms at 2 hours post-dose, so patients can indicate what that is for them, whether that's nausea, photophobia, etc. So here we can see, and this was not done with the triptan studies, so we don't have that data to compare to, but we can see that with ubrogepant, again, similar compared to the 2 doses, with Achieve-1 and Achieve-2, we're getting approximately 37 to 38% of patients indicating that at 2 hours they had, the lack of or absence of most bothersome symptoms. And then looking at some of the secondary efficacy results for ubrogepant here. So again, Achieve-1 and Achieve-2 were quite similar overall, but, and we can ignore the ubrogepant 25 milligram, I think, on this chart. It was done in some of the studies, it was looked at, but it's not coming to market at that dose, and we're just using the 50 or 100 milligram dose. So if we focus on those two, it's approximately somewhere again between 36 to 38% or so of patients are having sustained pain relief at 2 to 24 hours, and sustained pain freedom is lower there, so we can see that somewhere between sort of 12 to 15% or so. So kind of looking at it overall, it looks like there's a little bit less efficacy compared to the triptan medications, but we'll get to the tolerance part. I think that's the part that probably might be better than the triptans, in that it's generally better tolerated. So let's go on to rimegepant now. So a similar type of thing. This was the phase 3 studies, pivotal trials of rimegepant. Co-primary endpoints again, looking at freedom from pain at 2 hours. So very similar to the ubrogepant here, approximately 21% or so of patients had freedom from pain at 2 hours post-dose, and about 35% freedom from most bothersome symptoms at 2 hours. And then this is looking at pain relief through to 2 hours. So if we sort of focus on the 2-hour time point here, we have approximately 60% or so of patients that have pain relief at 2 hours post-dose. And then looking at sustained pain relief, 2 to 24 hours, approximately half of patients, or just under about 48% of rimegepant patients, and 2 to 24 hours, about 15%. So again, quite similar results to the ubrogepant. So in putting all of this together, there was a systematic review and network meta-analysis done actually comparing triptans and ditans, which we haven't talked about. And ditans, lasmiditan being the example, they're 5-HT1F receptor agonists, so similar to the triptans, except they work on a different part, not 5-HT1B, 1D, which are the triptans, but 5-HT1F. So they're not vasoconstrictors like the triptans are, because the triptans have serotonin receptors on blood vessels. So lasmiditan being the example of that, available in the US, but not coming to Canada, unfortunately. So we didn't discuss that. But this study, this systematic review, looked at the lasmiditan as well as gepants for acute migraine treatment. So they looked at overall 64 randomized clinical trials with over 46,000 participants, the majority of which were women between the ages of 36 to 43. And they basically found that pain freedom and pain relief at 2 hours with lasmiditan, rimegepant, and ubrogepant, they were associated with higher odds ratios versus placebo. So they certainly did a lot better than placebo, but lower odds ratio versus most triptans. So the triptans seem to have a little bit more efficacy overall at that 2-hour pain freedom point or pain relief point. But the gepants were associated with lower odds ratio for adverse events or side effects. So that's what we discussed there, that they do have that advantage of, even if they might be a little bit less effective, they have better tolerance generally. And the other important point I think that we talked about is that they haven't been associated with the medication overuse headache. So those are 2 benefits I think that we can use, and also another tool in the toolbox to use for patients that certainly don't respond to triptans or have inadequate response. So just a few words about the gepants in terms of the dosing. So rimegepant is 75 milligrams orally. Ubrogepant, like we talked about, comes in 50 milligram or 100 milligram tablets. And a second dose can be taken after 2 hours if needed for a maximum of 200 milligrams in 24 hours. I think the important thing with these gepants to keep in mind, though, is that strong CYP3A4 inhibitors, so these are medications like itraconazole or ketoconazole, some of the antibiotics like clarithromycin or erythromycin, certain calcium channel blockers like verapamil, there is an association with that, so we have to avoid the medication, for example, rimegepant, as well as generally we would avoid ubrogepant within 24 hours with those medications. And then if they're moderate or weaker inhibitors of this system, then using the lowest possible dose and limiting it to 1 dose a day is important. So just something to keep in mind. And then in terms of specific populations, so for rimegepant, there's no dose adjustment required for mild, moderate, or severe renal impairment, but we would avoid the use in end-stage renal disease. And no dose requirement for mild or moderate hepatic impairment, but we would, again, avoid in severe hepatic impairment. Ubrogepant, quite similar as well, so avoid in end-stage disease, whether that's renal or hepatic, and then use the lowest possible dose in that case, which is the 50 milligram dose. So just looking at the adverse events now and the safety of some of the acute therapies. So we talked about the triptans not being as well tolerated in some patients, and these are some of the side effects that we tend to see with them. So starting from the most common, they're dizziness, nausea, and fatigue, and kind of paresthesia, non-specific paresthesias being kind of the top few side effects that we see. But you could see that there's a whole range of things that patients describe with the triptans that they use. And we know that it's quite common. Most of our patients do describe, something that goes on with them. But most people still, tolerate it, so a lot of times it is still tolerable for patients to continue using them. But unfortunately, we do have some patients stop triptans because of these potential side effects. The other thing to mention is that, traditionally we've associated triptans with significant kind of cardiovascular concern, and not to use in patients that have cardiovascular disease because of their vasoconstrictive effects. But in fact, it seems like the risk at least is low. So it's not zero certainly, but we think that the risk is actually quite low. So the risk of cardiovascular, disease associated with triptans is supported by preclinical research and case reports and other emerging studies that suggest the risk is actually quite small. And there was a recent study that looked at over 13,000 people over 50 years of age who were prescribed a triptan. 19% of them were over the age of 65, compared to 41,000 triptan non-users. And they found that the vascular comorbidity is quite comparable in users and non-users of triptans, which suggests that triptan use does not increase vascular risk in patients over the age of 50. So age alone isn't a contraindication. And I think if they have well-controlled vascular risk factors, it could still also be used cautiously. We would certainly avoid in someone who's had active cardiovascular disease or stroke or anything like that, but I think that we shouldn't shy away from it if people do have some cardiovascular risk factors that are well-controlled, and the risk at least doesn't seem to be extremely high. So that's one thing to take away. Going on to ubrogepant in terms of adverse events, so generally quite well tolerated. So these were the adverse events reported by patients within 48 hours of either their initial or second dose in the pivotal clinical trials. So nausea, somnolence, dry mouth, and dizziness really were the main ones that came out as being significant, but even not really that much more compared to placebo, to be honest. And some of this can be associated with migraine, so it's hard to know how much of that is actually migraine versus medication side effect, but generally quite well tolerated. We went through that. Well, just to say that there was no serious adverse events as well reported within 48 hours for these. Yeah, rimegepant is also quite similar. So again, you'll see very similar side effect profiles, so nausea, dizziness. There's been some description of urinary tract infections with that, but again, it was just 1% of patients, so hard to know if that was a true association or not. Again, no serious adverse events. And with the older group of gepant medications, there had been concern previously of hepatic kind of issues, but in the more recent gepant development, that has not been a concern. Even in the cases where we do see a little bit of elevation of liver enzymes, usually it's not of major concern, and there's been nothing serious with that that's been seen in all the clinical studies done so far. So it seems quite safe. And then just to talk about the special population, so with pregnancy, there's no adequate data at this point on either rimegepant or ubrogepant, so we're not recommending using these. But the nice thing is that because they do have a short half-life, of somewhere between 5 to 11 hours, depending on the one you're looking at, a few days of stopping it before conception is adequate, whereas with the monoclonals that you'll hear about tomorrow or on Saturday with Dr. Nash, which are used for prevention, they have a long half-life of about a month or so, so they have to be stopped about 5 months prior to conceiving. So this is a great option for patients if they have future plans of pregnancy but not immediate plans, because it can be stopped quite quickly. Lactation, unfortunately, at this time as well, no data available, so we would at this time not prescribe it to lactating mothers. Pediatric population, Dr. Rajapasky might be able to speak on that. At this point in time, there's no data available, but the clinical trials are ongoing, so we look forward to receiving those clinical trial data. And then in the geriatric population, just to mention that there's limited data because there was a lower number of patients over the age of 65 in the studies, but no major clinically significant, pharmacokinetic differences have been noted. But of course, with the elderly, we do want to start generally slower, so you could use with ubrogepant the lower dose and then work up if needed. So just putting it all together in terms of considering an acute therapy for migraine, what are some of the things that we look at? So certainly we do need to look at the patient's comorbidities or contraindications to medication use. We need to look at the efficacy profile of the medication that they're using, tolerability, their preference. Some people will just say, I'm not going to do an injection, or I don't want to do a nasal spray, or I prefer not to do oral. So that definitely is an important factor. Looking at the refractory attacks and seeing what can be done to treat those in terms of combining therapies, for example, making sure they're taking their medication early on in the headache attack. Coverage, of course, unfortunately, a reality for us that we can't always use what we want. Coverage is an important one. And then risk of overuse as well, so certainly counseling them about that. And then regularly assessing the response to therapy, so essentially at every visit, seeing how they're doing with their acute therapy as well. So going on now to medication overuse headache. So this is a diagnostic criteria for medication overuse headache with the ICHD-3, so headaches occurring over 15 days a month in a patient with a pre-existing headache disorder. Most often migraine is where we see it, and regular overuse of more than 3 months of an acute headache medication. So ergots, triptans, opioids, or combination analgesics would be 10 or more days per month, and simple analgesics would be 15 or more days per month, and of course not better accounted for by another diagnosis. So you can see the GPANs are not in there because at this point in time, as mentioned, we don't feel that they're involved in the mechanisms that cause medication overuse. But just wanted to show you this graph because it nicely demonstrates that certain medications, including opioids and barbiturates, are actually a more causative agent for medication overuse or a higher kind of culprit. So particularly opioids, I would say barbiturates, luckily in Canada we don't use them as often, but opioids still, unfortunately, there's a high amount of patients that are on opioids. And you can see that it even starts at a higher level there in terms of probability of progression to chronic migraine. So you can see there with the opioids that patients are often starting at a high probability already of progressing to chronic migraine. And I think the reason for that is, of course, these are more disabled patients that already have a higher migraine frequency. But you can see that starting, anywhere from 4 to 6 days or higher, that graph goes up quite a bit more. So, the higher they are using per month of this medication, the worse it gets. With triptans, so around 8 to 10 days, we have that 10-day mark, but that's where the curve becomes sharper. Barbiturates, you can see it goes up very quickly, right after about 4 monthly days of use per month. And NSAIDs is a little bit slower, so again, around sort of that 8 to 10-day mark. Oh, sorry. So in terms of medication overuse headache, I think the one thing to remember though is that even though we do see it quite often, not all patients who overuse acute medications actually tend to develop medication overuse headache. Many of them do, but not all. So I think it's important to keep that in mind, and I think that medication overuse headache is a suspected diagnosis until the patient actually stops their overuse medications. One waits a while, usually around 3 months or so, to see how patients do, and then if they still have a high frequency of migraine, then they're actually chronic migraineurs. But if their headaches do improve, then I think at that point you can say definitively that they had medication overuse headache. And in terms of the treatment of suspected medication overuse headache, there's a number of things. So I think number one, patient education. So it's very important to let them know what medication overuse headache is, what's happening. Many of them may not know, or they're just doing it to function. I think a lot of patients just say, I need to go to work, or I need to take care of my kids. So unfortunately, a lot of them do that just to function. So I think education is a huge part of that. Discontinuation of the overused medication, but at the same time giving them something else that they can use when they get severe headache attacks. So giving them an alternative abortive medication. So here's something like a GPANT, or for example, something they haven't tried before would be a good option. But initiating preventive therapy at the same time as well. So whatever might be appropriate for them in terms of prevention. And then offering also transitional therapy. So some patients will get worse before they get better. So there's often a 2-week period where patients can get worsening headache before they get better. So for example, nerve blocks, again, might be a good choice here. Course of steroids, course of DHE, things that we can do to help mitigate that potential worsening before they start to feel better. And then very close follow-up is important as well. And so we're aware the prevalence of medication overuse headache is about 1 to 2% in the general population, but as high as 30 to 50% in the headache populations that we see in our headache clinic. So relatively high, unfortunately. All right, so just the last few slides on some of the pearls of wisdom for acute migraine treatment. So I think one important thing that we ask our patients is about their disability, but I think that patients actually often underreport their disability. So it's good to really ask, how is this affecting your function, your day-to-day function, your work, etc. So asking those concrete questions. And also asking about over-the-counter analgesics, because they will often not actually tell you how much they're taking, or they kind of forget about the Tylenol because it's over-the-counter. Treating early in the migraine attack, like we talked about, and treating according to headache severity, so it's that stratified care approach that we mentioned, so go to the appropriate medication right away based on the severity of the attack. Keeping adequate acute medications until the majority of attacks are controlled, so trying to manage most of those. And then just remembering that some attacks are going to be more difficult than others to treat, so having several different medication options, the parenteral options like we talked about, combining therapies, and then certainly considering prevention when that's appropriate. And Dr. Becker already mentioned Migraine Canada, and I just also wanted to mention that the Canadian Migraine Tracker, which is an app that's been developed by Canadian headache specialists and is also on the Migraine Canada website. It's a great way to keep track of headaches for patients. And again, Canadian Headache Society, a great resource for healthcare professionals. So thank you very much.